The ventrogluteal route. So let's break this down for a second. You recall from terminology that ventro is the same as anterior, which means the front. And gluteal is referring to the gluteus maximus, which is the muscle located at the superior aspect of the posterior leg, also known as the muscle that we sit upon. So the ventrogluteal injection is now considered the standard for glute injections. This is when we're using something that's very, very thick. You know, the medication is very thick, or we're using a huge volume, up to 5 milliliters. And these are deep muscle IM injections. Once again, it's an IM, so it's going to absorb quickly because of the vasculature involved in the muscle. It's considered to be more safe than doing the traditional gluteal injection. It's located in an area with a lot of bony landmarks. So once again, those landmarks we talked about when we're talking about the vastus lateralis, some of those are going to apply to this positioning as well. And this is considered to be a very low danger of hitting a blood vessel or any type of nerve in this location. The traditional gluteal injection was at a higher risk for that, and therefore it's the standard in the industry has been changed to ventrogluteal. And so we're going to examine that for a little bit. So once again, pay attention to the anatomy here. You have something called the iliac crest, which is the top of the pelvis, and that's a very important landmark. You also have something called the ASIS. That's how we refer to it in radiography. It's known as the anterior superior iliac spine. So it's abbreviated ASIS. And in radiology, we just call it the ASIS. And we use that particular landmark a lot. And then we have the greater trochanter again, which we mentioned in the vastus lateralis. So all those come into play when we talk about the ventrogluteal injection. So once again, iliac crest, you see that noted there. Then you see the ASIS. You see the location of the gluteus medius. So that area right there, there's a recession, a kind of a depression that goes in with that bone as it has sort of a concave shape to it. And there's a muscle that fills that area. And so we're using that muscle for the injection site. And there's the greater trochanter. So essentially what you do is you place the palm of the hand on the greater trochanter. You can see the thumb extend sort of to the groin area. That index finger will go all the way forward until you palpate the ASIS, the anterior superior iliac spine. And that creates a V between that and your second, or actually your third digit, your middle finger, which as you can see here is completely vertical. Within that V, you'll see that with the red X, that's our injection point. So once again, free of any major blood vessels, free of any major nerves, and considered to be a much safer site. I'm going to be honest with you, I've given maybe 3 or 4 ventrogluteal injections my entire career. We always use the traditional gluteal method, which we'll cover in a moment. But once again, this is considered to be safer, and we'll get into why in a few moments. So for this one, the patient's going to lie on the exam table on their side. If you're injecting into the right side of the patient, you're using your left hand for the landmark. If you're the left side of the patient, you're using the right hand as a landmark. And you can see the location here, so that's kind of on this anatomical dummy here, you can sort of see how we're starting. So here we have the left hand placed on the right hip, and it's placed so the palm is pressing down on the greater trochanter. Step 2, you palpate or feel the greater trochanter, the femur, and it feels firm and round, sort of like a golf ball-ish. It's actually quite larger than a golf ball, but it sort of has that texture to it. So, and once again, when we do these, we'll go ahead and go over how you can find that greater trochanter. It's pretty easy to find, easy to identify, and it's a very reliable landmark. Step 3, heel of the palm of the hand goes over the greater trochanter. The thumb goes towards the groin area, and index finger is then extended towards the ASIS, or the anterior iliac spine. And in doing so, we create the V. You want to make sure that digit number 3, your middle finger, is absolutely vertical on the patient. And if that's the case, and you're touching the ASIS with your index finger, and your palm's on the greater trochanter, there's only one place that can go, and that's straight in that V. And there it is, the injection site. So you spread the remaining 3 fingers away from the index finger with the middle finger pointing to the iliac crest, and give the injection in the center of the V that has been formed, exactly as we've been looking at. So that's our ventrogluteal. One more step involved, of course, Needle comes in at 90 degrees. This is one of those locations that you may be asked to aspirate to make sure you're not in a blood vessel. And of course, once again, slow, steady injection of the medication. So you just want to be really steady with the plunger, not too fast, not too slow. And of course, we want to note here, gloves were not used to show the proper hand placement. Knowing the rules of standard precautions and how we use PPE, you know that when you do this, you will be wearing gloves in all situations. Dorsogluteal. This is the one I mentioned before. We call this the traditional gluteal injection. It's no longer recommended. It's relatively close to the sciatic nerve. It is possible you can cause accidental injury. It says extreme caution must be exercised if this site is used. I wouldn't say extreme caution. If you follow the rules, it's really shouldn't be too much of an issue. And landmarks for the site must be carefully identified. So it's somewhat close to the sciatic nerve, but if you know proper technique, you can do a dorsogluteal without getting anywhere near the sciatic nerve. I've given thousands of these, and I have never hit a sciatic nerve. I've never had an issue with it whatsoever. In some respects, I find it easier than the ventrogluteal, and we're going to talk about it. We're not going to practice it. You should be aware of it in case someone asks you to use it. And if you're not comfortable with it and you do know the ventrogluteal, I would probably recommend using the ventrogluteal. However, we're going to cover it just so you're aware of what it is. So, by this criteria, the fact that it's not recommended anymore, it's only if there's no other muscle that can be accessed. And this is true, the second point. They shouldn't be used under children 3 years of age unless they've been walking for a year because the muscle's not going to be well developed. And you should be able to deliver whatever medication for a 3-year-old in the vastus lateralis. Large and obese patients will require a longer needle to ensure it reaches the muscle. Classically, we use a 1.5-inch needle for a dorsogluteal. So you may need something larger. I have never encountered anyone who needed more than an 1.5-inch needle, but it is possible. The landmarks are much simpler for a dorsogluteal than it is for the ventrogluteal. The buttock is divided into 4 quadrants. The injection site is the upper outer quadrant at a 90-degree angle, and that's really all the criteria involved. So to do this, of course, the patient has to expose the buttocks. You take a look at the buttocks, you see a line on the side. You can picture it right down the middle and right across the center, and then go up to the upper quadrant. It's kind of going to the outside of the posterior thigh and going straight in a 90-degree angle. Just so you know, as you're looking at this drawing where they have the X's here across the buttocks, the sciatic nerve is in the left upper quadrant, and it descends down into the lower left quadrant. It doesn't come anywhere near that right side unless you're already down into the leg. So having said that, it's pretty difficult to hit a sciatic nerve unless you're way off target. It is possible. I have heard of it happening. It's pretty rare. It is possible, as I said. But if you stay in that upper right quadrant of the buttock, it's very, very, very unlikely you're going to hit the sciatic nerve. In fact, I would venture to say nearly impossible. Unless maybe you had a 3-inch needle and you were angling it, toward the midline or something like that, which can be completely inappropriate and completely wrong. All right, so landmarks are given us here is the posterior superior iliac spine, the greater trochanter. You draw an imaginary line between the two. Inject into the upper outer quadrant, eject in a 90-degree angle. This is a second way of finding that dorsogluteal. I would recommend the first one. The quadrants work a lot better. You can see the location of the sciatic nerve here, and you can see the injection site, and you can see that there is a huge amount of difference between these, at least 6 inches or so. So once again, unless you've made a horrible error, the sciatic nerve should never come into play here. There are some blood vessels coming through there, but not any major ones that are going to cause any, huge, how do I want to say this, huge trauma if you were to hit them. Once again, you're not going to be using this technique. It's good to know about it. If someone tells you you specifically have to do this, just remember to go in that upper outside quadrant, and there's no way you're going to be hitting that sciatic nerve. Okay, so a Z-track method. This is usually done when we're going deep into a muscle and usually when we're delivering a lot of medication, and typically the type of medication that might stain. For instance, if we were doing an iron injection, we might use a Z-track method. It's used for IM only. You would never use this for sub-Q. The idea is to seal the medication within the muscle and to allow no exit path. So skin and sub-Q tissue are displaced about an inch to an inch and a half to the side prior to injection. The tissue is released immediately after the injection. So what that's really saying, if you look in A, you're using that right hand, to pull the skin tight in an opposite direction. Then the needle is inserted, injection is placed. When the needle is removed, the skin is released, and you see how it shifts back over. And when it does that, it blocks that route, and it keeps the medication from being able to backflow, or to move retrograde would be another way of saying backflow. It ensures that medication cannot move retrograde into the subcutaneous tissue. So dark colored medications, like I mentioned before, such as iron, and you get iron in the subcutaneous tissue or skin, it's not going to be harmful. It can stain the tissue, and for that reason, C-track is used. Also, once we get the medication, especially a large volume in the muscle, we don't want it to go back out, to go retrograde on us, or to leak out. So it's very effective for preventing that. Irritating medications, I mentioned before, testosterone and some of the hormone replacement therapies, we use the Z-track method. When you draw it up, you want to discard that needle and use a new needle for injection, and you may find the facility you work at is going to require that for all injections. It's not uncommon. But if you, in this particular case for the Z-track, you want to switch it out because this minimizes the tissue staining or irritation. Aspiration may be required, and do not massage this injection site. If you do, you're going to start moving things around. You're going to encourage that medication to retrograde flow out of the muscle back into the subcutaneous tissue, and you will have negated the entire process that you just initiated. So don't massage the injection site. Some considerations on the Z-track. Ask patient about any allergies to medications. If the dosage is 3 ml or greater, divide the dose into 2 syringes and inject 2 separate sites. Assess the patient's age, size, and muscle condition in deciding which route is to be used. And do not give an IM injection at a site where there is any indication of pain or tissue damage. Very important. You want to make sure you have good, healthy tissue that you're injecting into. Do not inject when muscle size and condition is not adequate. A 2 to 3 inch needle with large patients to ensure medication is injected into a muscle may be appropriate. Once again, site specific on that one. If a partial dose of a vaccine is administered because of the syringe or needle leaks or the patient jerks away, the dose should be repeated. Sometimes people will do what we call jumping off the needle right in the middle of an injection, and if they do so, you have to do the entire injection over. You can't just put that needle back in and continue. You stop, you set the safety on the syringe, drop it in the sharps, re-prepare the medication. In certain facilities, it might be appropriate to check with a supervisor or check with the doctor to see if they want you to give the remainder of the injection in terms of volume, or if they want you to just repeat the entire volume of the injection. But by no means should you ever reinsert a needle if a patient jumps off of it. If there's medication in the syringe, that's just going to have to be considered a waste. So set the safety, put it in the sharps, and follow your protocol that you've been instructed. If you're not aware of the protocol, check with someone. Say, hey, I got a 1/4 ml in this patient. It should have been a 1/2 ml. They jumped off the needle. Do you want me to give them an additional 1/4 ml, or do you want me to give them the entire 1/2 ml? That would be an example of a question that you would ask. Okay, we're going to talk about multiple injection sites in just a moment, and that will be the last part of our lecture for today. We're out of time on this particular segment, so we'll pick the rest of that information up in the next shorter segment.